So we come to the last lecture by Professor Lise Nigrovic, which is a professor of pediatrics and emergency medicine at the Boston Children's Hospital. She dedicated a lot of her research on Lyme disease. So her lecture will be on this issue. Thank you, Lise.
Thank you for staying. This is much more clinical. There aren't any pictures of cells. As you were saying, my own research for the last decade or so has been focused on the management of Lyme disease in children who present to the emergency department. And as a clinical researcher, the topics that I've chosen to study have really stemmed from my observations in the clinic. You take care of patients and you know what is known and what is not known, and the unknowns lead to great research avenues. And so I find Lyme disease a very interesting topic. I know, how many people have ever seen a patient with Lyme disease? Maybe I shouldn't ask this question. Uh-oh. All right, a few. Okay, a few. Good. It's an area of emerging Lyme disease here in Italy, and hopefully I'll convince you that it's an area of importance to know something about clinically. And I think over time you will see a patient who's either been infected here in this area or who's returning from travel abroad, because there's certainly a lot of Lyme in Europe. More in Northern Europe, but increasingly in Italy. So hopefully I will convince you to think about Lyme, to suspect Lyme, and know how to diagnose and treat if it ends up being Lyme. Okay, I do have a disclosure of somewhat relevance to this talk. So I have a research grant from Pfizer to study the epidemiology of Lyme disease in children. And so although I'm not going to talk about any of that work really today because we're just starting that study. That's a disclosure here. And this is one of our favorite places in Vermont, which is one of the northern states in the US, and our favorite dog, Willow, a golden retriever who loves running and bringing home ticks. So we'll have a matter of background. We're going to talk about, so we'll have common ground in thinking about Lyme disease, and then we'll finish with 6 cases which illustrate different treatment and testing issues related to Lyme. So children get Lyme disease. I don't think I need to convince this group, but here's some data from the United States looking at the AIDS distribution of patients that get Lyme disease. So on the x-axis, we have the age in 5-year groups, and then the y-axis is cases per 100,000 population. And this is across the US. And so you'll see a bimodal distribution. In this figure, there's a peak in 5 to 10-year-olds, and then again in sort of middle age or older age. And the thought is these are the groups of patients that have the most time to spend outside. So the 5 to 10-year-old kids, they're playing outside, they're in the grass, they're climbing trees. And then again, in sort of older adulthood, as you retire from your working life, you have more recreational time outside. And so that's why there's 2 peaks of the age. In all age group, Lyme disease is more common in males than females. Again, that may reflect time outside and the types of activities that males are doing compared to females. How does Lyme disease present? There's different flavors of Lyme disease, different stages, and not all patients follow the textbook in terms of which stage where they present. But classically, the earliest stage is the early localized, and that'll present with a classic rash or lesion called erythema migrans, or EM. And here's shown a picture of a classic EM. Classically, it measures more than 5 centimeters in width, and it has a bullseye appearance. So the outer red and the inner red, and then the lighter area. The second stage is the early disseminated phase. This would be sort of weeks to months after the tick bite. The early localized can be days to weeks after the tick bite. And that includes multiple lesions. So most patients have a single EM lesion, but some patients have multiple across their body. The early disseminated phases also includes cranial neuritis, most commonly the facial nerve palsy, as shown in this girl here. It can include meningitis, carditis. As parts of the early disseminated phase. And the late acute phase presents as arthritis. And this is a patient with a right knee arthritis. The knee is the most commonly affected joint. Okay, talk a little bit about how Lyme disease may differ in Europe versus North America. So first of all, it's the pathogen. So this is Lyme disease is caused by a bacteria, Borrelia species bacteria, but the specific species differs. So in Europe, it's Afzelii and Garenia. and in the United States is Borrelia burgdorferi. The vector, the tick that spreads the infection, in Europe it's Ixodes ricinus, and in the United States it's Ixodes scapularis. There's also a Ixodes pacificus tick that is shown to spread the bacterium on the west coast of the United States. I'll show some pictures and a few slides of those ticks. I can't tell the difference, but those that are experts in ticks probably can tell the difference between the Ixodes species. The clinical manifestations differ in general. So in Europe, there's much more neurologic Lyme disease. And in North America, there's more arthritis as a manifestation. It's not clear why that is. As we said, the bacteria differ. And so perhaps it's something different about the infecting organism, or it's something different about the host in the manifestations of disease. And so that's an area of uncertainty, an area to investigate. And then the skin findings, which are the most common manifestations in both regions, differ a bit. So I showed you the picture of the erythema migrans lesion. That's more common in the United States. It's also seen here in Europe. But there are these skin findings, Borrelia lymphocytoma and acrodermatitis chronica atropicans, which are really not seen in the US at all, but are described more commonly here. They're not common manifestations, but they are manifestations seen here too. What about the season? So this is a temporal disease. And so when the patient is presenting has to integrate into your decision making. So the early localized and early disseminated manifestations, the rashes, the facial palsy, the meningitis, present mostly in the summer months, May through August. And this graph here shows the months of the year and the percent of the Lyme cases seen by month of the year. So the graph on the left is the early localized and early disseminated. It's very unusual to see Lyme facial palsy in January and February because the ticks bite in the summer months and then the infection occurs weeks to months after the tick bite. However, arthritis is a bit different. So arthritis can occur, months to even years after the initial tick bite. And so Lyme arthritis occurs throughout the year, and it's important to remember. So if you see a child with a swollen knee in February, it could be Lyme disease, whereas a facial palsy in the winter months is unlikely to be Lyme disease. And it depends a little bit on your climate and how cold it is in the winter months, how broad the shoulders are. So we see in more temperate zones in the US that there are broader shoulders. So we see Lyme earlier in the year and later into the fall. What about the disease is spreading? So there is more Lyme than there used to be. So Lyme was first described as a cluster of arthritis cases. This is the actual publication from Arthritis and Rheumatism from 1977. And so it's an epidemic of oligoarticular arthritis in children and adults in 3 Connecticut communities. So there was a cluster of arthritis cases. It was actually the mothers of these patients who said something is going on in this very small community where these patients are developing arthritis. And so it was an epidemic form of arthritis that's occurring in eastern Connecticut since 1972 with a peak incidence of new cases in the summer and early fall. It's clustering in some areas and become of a characteristic preceding skin lesion, the EM lesion, in some patients. So they studied 51 residents of this region. And this investigation, which was led by a young rheumatologist from Yale University by the name of Alan Steer, led to the discovery and the description of Lyme arthritis. He's sort of the father of this clinical field in the US, where he did the epidemiology investigation to discover that it was a tick-borne arthroped disease. And then collaborated on some of the work that led to the discovery of the infecting organism by William Burgdorferi in 1984. So the cases were described in the 70s, but the organism was isolated as the causative agent. The disease has probably been around for far longer, but it was sort of recognized as an entity in this time period. How does it look now? So the CDC in the US has tracked Lyme disease cases, and their current approach is to use a laboratory-based surveillance method. So they go to regional laboratories and they collect results of the diagnostic testing, and they report states as either high incidence, which are the ones shown in blue, and then the lighter blue are lower incidence. And the definition of high incidence is more than 10 cases per 100,000 population in the state. So We come from Massachusetts, which is on the East Coast with the little hook, the arm on the end. That's Cape Cod. And that's a high incidence state, and it's been high incidence for a long time. But the blue area is spreading north into New England, the upper part of the United States, into the mid-Atlantic region, and spreading west. And Lyme disease cases are described in every state of the United States, but the predominance is, as shown here, on the East Coast and the upper Midwest region. Okay, what about Italy? So I found this great paper, which was published in 2023, and it's a 10-year investigation of Lyme disease in Italy. And so they identified 20 hospitals that are shown here by the green dots. And I noticed that Udine and Trieste were some of the collaborating centers, so you can see the upper green dots. And they just reported all their cases over a 10-year period. And so those two hospitals reported 517 cases over 10 years. So that were recognized and diagnosed. So although the absolute numbers are not that high over that long time period, you are living and working in a region where it's the higher incidence of Lyme disease in your country. And I think that, and we'll talk about vaccination, but in the absence of vaccination, those incidents are only to increase over time. So you may be seeing cases, and you also are seeing people that return from traveling from areas where Lyme really is more endemic. So Germany, Sweden, Finland, other areas like that, Northern European areas have a very lot of Lyme disease, a little bit colder areas than here in Italy. Okay, and what about prevention? Maybe why can't we just prevent this disease so we don't have to worry about that? Current prevention measures are inadequate. So one approach would be repellent. So you use a bug spray or an insect spray. If you use a spray that includes DEET, that can be protective against ticks as well. Permethrin is a tick-specific repellent that you can put on. It's really hard to remember to put on repellents every time you go outside. There can be some toxicity, some uncertainty about using those chemicals on skin, especially for young children. Some parents don't want to do that. Protective clothing is another approach. So it's recommended if you go into a wooded area. And the highest risk areas for getting Lyme disease are not the deep woods or your backyard, but it's the areas right between your backyard and the woods. So the transitional areas, the tall grasses that are right beside wood. And so it's recommended if you're going to be in that area to prevent Lyme disease to wear long pants, long shirt, tuck your pants into your shirt. This is a picture of our son who's actually visiting with us this trip. He's off on his own with his friend when he was maybe 10 years old. But this was deep winter and a very cold time, and he's wearing shorts. And so I'm just saying that most children are fairly reluctant to wear long pants, and so that strategy can be hard to apply. Our son certainly would never have complied with that. Tick checks are also hard. One, you have to remember to do it every time you've gone outside. And as we'll see, the ticks that spread this disease are really, really tiny. So even if you check, you often don't see the tick. This is a way of looking at these ticks and seeing how small they are. So this is a public information campaign by the CDC a decade ago, 2018, but I think the picture is really great. The nymphal ticks, the baby ticks, are the ones that spread the majority of the disease, and they're really, really tiny. So this poppy seed muffin shown here, 5 of the poppy seeds are actually ticks, little nymphal ticks. They're really, really tiny to see. There's no breakfast being served, so but and you can imagine that you wouldn't see if a tick that small bit you. And to sort of highlight that point, in our work in the emergency department, we enroll children who end up having Lyme disease, and we ask the parents, do you remember your child having any tick bite of any sort in the last year? And of the children who end up having Lyme disease, only 1 in 5 say, oh yeah, they had 1 tick bite over the last year. We're not identifying the tick. We're not, determining that it was an Ixodes tick. And then the patients who were tested for Lyme disease but don't end up having Lyme disease, it's 1 in 10. So the history of the tick bite is associated with having Lyme disease, but it certainly doesn't rule out Lyme disease. And in fact, 80% of children who have confirmed Lyme disease, no one remembers the tick bite. And I think it really speaks to how small these ticks are. And so, it's important to remember if they don't recall a tick, that doesn't mean that they don't have Lyme disease. What about the vaccine? So in the US, there was a vaccine called Lymerix, which was an OPS-A vaccine that was licensed in 1998. And I don't believe it was licensed. I actually didn't look this up, whether it was licensed in Europe ever. But in 2002, it was removed from the market for a couple of reasons. One, the demand wasn't very high. It was never recommended to get the vaccine, so people weren't buying very much of it. And some people got the vaccine and said they got symptoms from the vaccine, particularly arthritis that they attributed to the vaccine. That was investigated in a rigorous scientific manner, and it was felt like they were just getting arthritis in sort of the background rate. It just happened to coincide with the vaccine, but the sort of public outcry and the lack of sales led the manufacturer to pull it from the market. And we haven't had a vaccine available since 2002. There is a vaccine available for pets, and so we get our dog vaccinated against Lyme disease every year, but there hasn't been a human vaccine since 2002. There is a new vaccine that's being developed. It's primarily being studied by Pfizer, but it was actually developed by Valneva, which is a Swiss company. And it's an OPS-A vaccine, but it's a different target than the first vaccine to kind of get around that concern about side effects. It's currently undergoing phase 3 trials. They've enrolled all their patients, children and adults, and now they're just waiting to see whether the patients who are vaccinated get Lyme disease or not. And they're anticipated to have enough data to go for licensure, both in the US and in Europe. And in fact, they may get it licensed in Europe first because our climate in the US for vaccines is really antagonistic right now. So it may be available in Europe earlier. I don't know. But if it proves to be effective. Importantly, they included children down to 5 years of age in their initial study. The prior Lyme vaccine did not include children, and as we showed in the age distribution, children get Lyme disease, so they're an important group to consider vaccination if the risk is high. So in the next year or two, we may see trial results and licensure of this vaccine product. Other approaches to vaccinate against Lyme disease, the mRNA approach that we all learned about in the COVID pandemic, people are exploring, but those vaccine target or the development are very far. They're not in human trials yet. So there will be some movement in the Lyme vaccine world. And then the question will be who will get it and how effective it is. Okay. And lastly, how do you diagnose Lyme disease and what are the limitations of our current approach to diagnosis? So the first is a test-based approach, and the second is an examination-based approach. So in a patient who's symptomatic, you do a Lyme disease test. And Lyme disease tests are two-tiered tests. They're a first-tier test, a sensitive ELISA screening test, followed by a confirmatory test. And there's sort of two flavors of two-tier testing. One is called the standard two-tier testing, which is an EIA test followed by an immunoblot or a Western blot. And I understand that's your test that you would order here if you were to obtain Lyme disease tests. I think I learned in my laboratory tour that your Lyme disease tests are done in the clinical lab at Trieste. But so the samples would be sent and probably take a few days to return their results. So, and that we also wait for results as well using regional laboratories or commercial laboratories. In the US, there's increasing movement toward it's called a modified two-tier. And so it's an ELISA test followed by a separate orthogonal ELISA with a second target. And they're a little bit more easier operationally for the labs because ELISA tests are much easier than immunoblots to perform and interpret. And there's some evidence that they're more sensitive in early disease. So both tests are accepted, but there's a movement toward the modified two-tier approach currently. And importantly, you're gonna have to tell me when I'm done. I didn't work on the timer. The important thing is that if you have a positive test, you also have to have symptoms of Lyme disease. So if you have a completely asymptomatic patient who has a Lyme disease test ordered for some reason, and it comes back positive, that's not Lyme disease. So that's evidence of prior infection or a false positive test. And so that's why it's important that you're sending the test in patients where you're clinically considering the condition. Alternately, if you have the rash, the erythema migrans rash, that itself is diagnostic. And that's partly because our tests don't perform well in the setting of the rash. And we'll come back to that. So symptoms of disease plus a positive test or the rash are diagnostic of Lyme disease. There are limitations that are well recognized of the current diagnostic approach. So false negatives, so people that have the disease but don't test positive. So first of all, I've shown you very classic EM lesions. They don't always look that classic. They can have atypical appearances. So someone may look at the lesion on the skin and think, oh, that's ringworm, that's cellulitis, and miss that it's actually an EM lesion. It can have an atypical location. The picture that I've shown here is a very classic EM lesion, but it's half hidden by the hair. So you could imagine, if the hair was held, on the, not pulled back behind the ear, that you would only see the red rash on the cheek, and you might think it's a cellulitis or something like that. Very commonly in dark-skinned individuals, you don't see an erythematous rash. It's very hard to diagnose, and rashes look different. And so I think there can be some misclassification or missing of the skin manifestations of disease in general, but also with Lyme disease in darkly pigmented individuals. And then in early disease, the diagnostic test may not be positive. There's serologic response. You have to have an immune response to disease. So there's this window period that you have where you're not directly detecting the pathogen, but looking for the host response to pathogen, where you don't have an immunologic response, but you do have disease. There's also a problem of false positives. That is somebody who has a positive test but doesn't have disease. That can happen if somebody says that a cellulitis rash is an EM lesion. Also, the issue of previous infection. So it's a serologic test. You have Lyme disease one summer because you spend it in the United States on one of the islands where it's very endemic. And then you come back and you have a fever and somebody's worried about Lyme disease. You may still have positive serology from your infection a year ago. And the current tests don't distinguish between prior infection and current infection. So that's one of the limitations. One study, we looked at children who were having bone reduction. So they were in the emergency room for a trauma-related reason. And we chose that group of patients because they were having IVs placed. And so we could grab some blood, and we got consent for blood. And then we did Lyme tests on 300 patients that had no evidence of Lyme disease. And 1.6% of them ended up being testing positive. That's considered sort of the background seroprevalence of Lyme disease in endemic areas. These maps show different regions in the US that don't mean much to you, but they're areas where Lyme disease is endemic, and the blue dots show where these patients live. So they lived in endemic areas. They probably had Lyme disease in one of the preceding years. And when you look in adults, this rate of background seroprevalence is more like 5 to 7% in endemic areas. And so you can see that that can get kind of confusing, and one of the reasons we need a better approach to diagnosis. And lastly, the delay issue. You send your labs to a collaborating laboratory, the specimen has to be sent. If the first tier test is positive, they have to do the second tier. So you're waiting several days, I would assume, for the results. We also wait several days. And as a clinician, you have to make decisions about antibiotics, no antibiotics, hospitalization, no hospitalization. And so that delay is a challenge for a frontline provider while you wait for the results, because you have to make your decisions before you have complete information. Here, we're going to go into 6 cases that talk about the different manifestations of Lyme disease. Any background questions? You can save them at the end. Okay, so this is the first case. This is somebody I saw in the emergency room a few years ago. This is an autistic child who slept every night with his dog. And when they woke up in the morning, the mom noticed the insect, the tick in the upper lid, presumably transferred from the dog that he shared the bed with. And so they started the day going to the pediatrician's office. And I mentioned that he's autistic only to say that, it's hard to do procedures on autistic children. And so the pediatrician tried to get the tick out, but he wasn't that cooperative in the office. He ended up going to an urgent care where they also had similar difficulties. And so I saw him in the evening in the emergency department after having a very frustrating day for the family. But, the issue is a tick, and the tick is still there. And so we need to remove that. So promise some pictures of ticks. So the first issue when you see a patient with a tick is what kind of tick is there? Because if it's an ixodes tick, you have to think about the risk of Lyme disease. So on the left, it gives you sort of a size graph of the ixodes tick. And the adult tick, is these are inches, sorry, this would be centimeters in a European figure, but probably about a centimeter. And the adult female is bigger than the adult male, and the adult female is much prettier with the red belly. But again, we said that it was the nymphal ticks that spread the disease, and those are just a couple millimeters in size, really tiny. We don't seem to like ticks. There are other ticks that are common, so Lone Star ticks and dog ticks that are much bigger, more brown. And so if your patient has a tick that's one of the other species, you want to get the tick off, but you don't have to worry about the transmission of Lyme disease. This picture on the right is the Ixodes ricinus tick, which looks exactly like an Ixodes scapularis tick to me. So I think only the entomologist can tell the difference, but it's that red belly on the female tick. Okay. In addition to removing the tick, the other issue you have to think about is post-exposure prophylaxis. And this is relatively routine in the US, and I understand very uncommon in Europe. But the data that it's based on is a randomized trial that was published 25 years ago almost in the New England Journal of Medicine. And what they did is they enrolled patients 12 years and up or older who lived in a Lyme disease endemic area. It was pretty much Connecticut and the Long Island area of New York, which is highly endemic for Lyme disease. And so to be enrolled in this study, you had to have an Ixodes scapularis tick, which was attached for 24 hours. And they actually had at each of the enrolling sites, somebody who was an expert in ticks who could say, yes, this is definitely an Ixodes tick, and you had to have it in place for 24 hours. And so if that was the case, they would help you remove the tick, and then you were randomized to getting a single dose of doxycycline or not getting doxycycline. And then they followed the patients for 6 weeks. And so in the patients that received doxycycline, 0.4% of them got Lyme disease by 6 weeks, and in the placebo group, 3.2%. So those statistically different, with less patients that received the doxycycline getting the Lyme disease. And because they only followed them for 6 weeks, this was essentially all erythema migrans rash, because that's the acute manifestation. It's also the most common manifestation. There were more side effects in the doxycycline group, but these are mild side effects, GI upset, sun sensitivity, but they were statistically more side effects in those. So based on this study, it is common practice in the United States to give a single dose of doxycycline after a tick bite that's suspected to be Ixodes scapularis, which has been attached for 24 hours. Now, the reality is sometimes you don't know exactly which tick it is because they don't bring it in and it's lost and you can't tell from their pictures. And sometimes you don't know how long it's in place because you have to just make the best guess based on their environmental exposure or how engorged the tick looks. But I understand in Europe that it's more of a watch and wait. So treat Lyme disease if it develops. But this is where this practice comes from. So for this boy in the ED, we had to take a combination of behavioral and medication responses. So, we had child life team, distraction. By the time we saw him, he was so exhausted from his day that might have been on our side. So we were able to distract him. We gave him some medication for anxiolysis, intranasal midazolam, and removed the tick, fortunately. And we did think it was an Ixodes tick by the best of our ability. We didn't send it for any formal testing. You can send ticks for testing, both to confirm the tick species and also to look for the Borrelia bacteria within the tick. However, those tests are not recommended. They're not standardized. And at least in the US, the patients have to pay for them because they aren't recommended. And even if you had Borrelia in your tick that you were bitten with, it doesn't mean that that was transmitted to you. So we don't know what to do with that information. So tick testing is not recommended. But because we think the child had the tick on for about 24 hours, because it had been the night and the day, we did offer, and the parent wanted doxycycline prophylaxis. We were able to give it while they were right with us in the emergency department, so there wasn't a medication to pick up. It was very easy. And I called the mom a few weeks later, and the child was doing fine, never developed Lyme disease. I didn't follow him long term, but he had a good outcome, as would most patients if they hadn't received the prophylaxis. Remember, 3% of those that got the doxy, not 3%, so 3% of those that had the placebo got Lyme disease and 0.4% that had doxy. Even without prophylaxis, 97% of patients that have a tick bite for more than 24 hours are not going to have Lyme disease. So, it just depends how you approach that low risk. You can reduce the risk, but the risk, even without prophylaxis, is quite low. Okay, we're going to move on to our second case. 18-year-old boy with a rash on his back. Look familiar? Rash. So we're thinking this is erythema migrans. It has the ring on the outside and the central clearings. Fairly classic, but each rash tends to look different. It's quite large. This is a 18-year-old adolescent boy, so it probably measures 20 centimeters at its wide. So I think this would be diagnostic of an EM lesion. So then the question is, okay, we think it's Lyme disease, and that alone can be diagnostic, but maybe you're not quite sure. You haven't seen that many cases. It's unusual in your region. Should you study it, send a blood test, and will that help you at all? So the problem is that, again, Lyme disease testing is serology. They're looking for the host's response to infection. It's an immunologic response. And so the serology does not perform that well in the EM lesions. So if you do your first-year test, if you have multiple EMs, the sensitivity is 80%. So multiple EMs are part of early disseminated disease. And so the test starts to be somewhat effective, 80% sensitive. But if you do the first tier test in a patient with a single EM, the sensitivity is only 47%. And if you confirm it with the two-tier serology, which is the confirmatory test, again, 74% of patients with multiple EM are going to have a positive serologic test, and only 36% of those with a single EM are going to have a positive test. This is based on a cohort of a couple hundred children or 150 children with EM. All this taken together is that, the tests are better in multiple than single EM, but the tests are just not that good in the setting of a rash because it's such an early manifestation. So the recommendation is probably not to obtain a test. Just diagnose it clinically and start your treatment. Doesn't help you. If it comes back positive, it affirms you, but if you have a negative test, it doesn't help, and it may just lead to confusion and money, and most children don't like having their blood tested. Okay, so what about this child? So no testing obtained. It's a classic EM lesion treated with doxycycline, which is really at this time sort of the frontline treatment for Lyme disease in children of all ages, and had a complete recovery. All right, moving on to another manifestation of early disseminated Lyme disease. This is a boy who's 2 years old, who was previously well. He woke up in the morning, and the mom, said there's something wrong with his face. And she, got him dressed and gave him a bottle. And when he took the bottle, the milk was drooling out of the right side of his face. So she decided to bring him right away to the emergency department. And you see him in mom's arms, and you're seeing also that the right side of the face looks like the mouth is turned down. Although it's quite subtle, and I think the mom notices it right away, but you have to watch it to make sure you don't miss these kind of subtle findings. It's hard in a young child to sort of ask them to do the provocative maneuvers that you might to diagnose a facial palsy, but you just watch them and see them in their different natural expressions. I have 2 pictures here, but what you see as he's, moving his face naturally is that as he smiles, the left side of his mouth turns up and the left eye swishes together, but the right eye is wide open and the mouth doesn't turn. And if you can see it, the forehead musculature isn't moving at all. So both sides of the forehead musculature are involved. So whenever you see someone with a child, adult with facial palsy, the first decision is it peripheral, is it central? And the key to that is assessing the forehead musculature. So if it's a peripheral facial palsy, then you're going to have involvement of the forehead musculature because the peripheral nerve innervates, the 3 zones of the face. And so you're going to have involvement of the forehead, the eye, and the mouth. But if it's a central nervous palsy, then the forehead musculature movement is going to be preserved. And that's because the forehead is innervated by both cerebral hemispheres. And so if it's a central cause, like a stroke, then your forehead musculature is still going to move. And so that can be subtle and hard to see in a young child. You have to observe them for a while through the normal expressions. But that's sort of distinguished between a peripheral and a central palsy. And a central palsy is a different, different workup, different etiology than a peripheral. And a peripheral is much more benign etiologies. And in fact, in our setting, it's essentially something called Bell's palsy or idiopathic facial palsy or Lyme disease. And how can you tell the difference? So things that are associated with having Lyme disease is the season. So in July, you're suspecting Lyme disease more than you would in February or March. Patients that present with a fever or have systemic neurologic symptoms like headache are more likely to have Lyme disease versus Bell's palsy. And those have been shown in a couple studies, both Boston Children's and other centers located in Lyme disease endemic areas in North America. So in terms of this child who presented, you would assess what are the clinical factors. Has the child had an opportunity to play outside? Have they had potential exposure to ticks? So a young infant who's never laid in the grass is probably not going to have Lyme disease. A toddler who's learning to walk and lives, with a backyard that backs up into woods is more likely to have exposure. What month of the year is it? So that's sort of the geotemporal risk of Lyme disease. So if you're considering Lyme disease as a possibility, you would want to send a test because the performance of test in the setting of facial palsy is much better. So first tier test, this is a standard test, would be positive, and that would reflex to a confirmatory test, which is either an EIA or an immunoblot. And the interpretation of both immunoblot or second tier EIA tests are positive. So if this patient has Lyme disease facial palsy, which is treated with doxycycline, the recommended treatment length is about 14 days. It's also important to remember for Lyme facial palsy or any kinds of facial palsy is they don't blink enough. And so you can have dryness of the eye and injury to the eye. So always want to use some eye lubrication of some sort, especially with sleep. They're susceptible to eye injury if you forget the eye lubrication. It takes a while to get better from facial palsy, regardless of the cause. So in terms of precautionary anticipatory guidance for your families, you want to tell them it's going to take, 5 weeks, 6 weeks for that facial nerve to recover because it has to reinnervate. And that's for Lyme facial palsy or Bell's palsy. So I think a lot of uncertainty and expectations with the family, they expect they'll take the antibiotics for a few days and the nerve will be better. It really does take a while to get better. The ultimate recovery is almost universal. So it will come back, but it just takes a little while. And so that's hard, particularly for the adolescent patients. This is a very hard manifestation. They feel, because it's cosmetically impactful. So it can be very hard for them, even if it's a benign disease ultimately. Okay. This case is a 7-year-old girl who presents in the summer months with a headache and neck pain and low-grade fever. You get some peripheral white blood cell count, which is 12,000, sort of in the middle, 40% polys. And because of the headache and neck pain, you're worried about CNS infection, so you obtain a lumbar puncture. So the results are shown here. You have a mild pleocytosis, moderate pleocytosis, 250 white cells, 20% polys, 60% lymphs, and 15% monocytes. I'll just highlight here, there's a category of mononuclear cells, which is the combination of lymphocytes and monocytes. So this patient has 75% mononuclear cells. Non-traumatic TAP and the glucose protein are normal. And when you look for bacterial organisms on the spinal fluid, that test comes back negative. So you send a Lyme test, but we're going to need to wait a few days for the results. And so the patient's in your emergency department, and you need to decide, are you going to do antibiotics or are you going to hospitalize the child? So we have a clinical prediction rule made by a colleague of mine called the rule of 7. So it's clever. It has 3 factors and they all involve 7. So the things that are associated with Lyme disease meningitis versus other kinds of viral meningitis, most commonly enteroviral meningitis, are shown here. So more than 7 days of headache. So Lyme meningitis tends to be a subacute process. So you've been sick for a while by the time you're diagnosed. 7th or other cranial nerve palsy is associated with Lyme disease, and greater than 75% CSF mononuclear cells. Again, the combination of lymphocytes and monocytes. So if you have none of those predictors, that patient is at low risk for Lyme meningitis. If you have one or more, the patient is not low risk. So if you're considering viral meningitis versus Lyme meningitis and you have none of the rule of 7 factors, it could be safe to assume that Lyme is unlikely. Another way to increase your probability of certainty is using your molecular diagnostics that you do have here, like an enteroviral PCR or multiplex panel. And that might give you the answer more quickly and more accurately than a discriminative rule. But tests aren't available real time in every clinical setting. And so you're lucky here to have such a comprehensive approach to microbiologic diagnoses. Okay, how well does this rule done? We've done a meta-analysis of 7 published studies that looked at this rule. It was fairly sensitive, 98%. Specificity of rules for identifying low-risk patients are often modest, and this rule had a 40% specificity with a high negative predictive value. So if you're in the low-risk group, fairly low risk of having Lyme meningitis. One of the things to remember, as opposed to bacterial meningitis, which is very important to diagnose quickly, Lyme meningitis also often has a subacute presentation. So if you're wrong and think they're low risk and send them home and then call them back when their test comes back positive 2 or 3 days later, that probably is appropriate management as well. This child had 2 high-risk factors, both the duration of symptoms as well as having more than 70% mononuclear cells. So Lyme was highly suspected. So they ended up being discharged on doxycycline antibiotics, and the treatment length for Lyme meningitis is between 14 to 21 days with clinician discretion of the length of therapy. Their tests come back positive a few days later with a positive first-tier test and then a positive IgM and negative IgG. This is common in Lyme meningitis where you have just the IgM that's positive without the IgG because it's an early manifestation. Patients that have been sick for longer than 30 days should probably have an IgG as well well as an IgM, and the IgM alone can be a false positive in the setting of chronic disease. But in this setting, it's very common to just have the IgM positive. Patient was treated and got better. How should you treat Lyme meningitis? I'll do a little divergent because this is an area of interest for me. So the IDSA guideline, which I know is the International Infection Disease Society of America, so this refers to what we look to for our treatment guidelines, back in 2006 made a guideline that said every patient with Lyme meningitis should get ceftriaxone. Ceftriaxone is a complicated therapy to give for 2 to 3 weeks. So, and when you look at giving long courses of a parenteral antibiotic, there are complications. And so 1/3 of children treated for 2 to 3 weeks with ceftriaxone a complication. Those complications were antibiotic reactions, as well as complications of the lines that were put in to deliver the antibiotic. So it's not a simple therapy, even in a healthy patient. And so what about doxycycline? And so the data for this really stems from Europe. These studies were done in Sweden and in Finland. There's 2 adult randomized controlled trials of randomizing patients to ceftriaxone versus doxycycline. And the doxycycline patients did just as well as the ceftriaxone patients. They were relatively small and they were only powered to look at short-term outcomes. So their symptoms got better, but suggestive information that doxycycline was just as good. In the US, there's no randomized trials. There's a single center pediatric experience from Pittsburgh, an area where there's a really lot of Lyme disease. And their infectious disease clinician just said, I think doxy is just as good based on the European data. And so they just changed their practice locally and they published their experience with their first 38 patients and they all did fine. So small study, no control group, but some suggestion that maybe doxy is fine. Based on that suggestion, the new IDSA guideline was more broad. So guidelines are often clinical questions, PICO questions, and then they give you an answer based on the best available evidence. So what are the preferred antibiotic regimens for the treatment of acute neurologic manifestations of Lyme disease with or without parenchymal involvement of the brain or spinal cord? So this is Lyme meningitis. So in patients with Lyme meningitis, we recommend using intravenous ceftriaxone, cefotaxime, Pen-G, or oral doxycycline. Pen-G is also given intravenously and has to be given every 4 hours, so I don't really see that used really at all. But this guideline says either the 3rd generation cephalosporins or oral doxy are equivalent. Now, again, this is based on relatively low quality evidence, a suggestion that it's the same, but doxycycline is so much easier to give that it's led to a fairly rapid change in practice. I did check the European guidelines for Lyme meningitis, and it does suggest that either is effective treatment. Although an important difference with the European guidelines is that the diagnostic criteria for Lyme meningitis require a spinal tap and an antibody index of the spinal fluid to the peripheral blood. So an additional test, which we don't routinely do in the US, we rely on peripheral serology. So there are some differences in the approach based on the European guidelines. This is something of great interest to me. So, is doxy as good as ceftriaxone? And so as practice has been changing, we're doing a study that's funded by the NIH in the US to look at the differences in the effectiveness of treatment. So our goal is to compare oral doxy to intravenous ceftriaxone for Lyme meningitis, both on how long your symptoms take to recover and sort of long-term 6-month quality of life. So maybe your symptoms get better, but your long-term outcomes are not as good. So we're really trying to look at the whole experience for the patient and the family. We hypothesize that doxy is not inferior to ceftriaxone, but this study is powered to demonstrate that, to be sure that our change in practice is justified for short and long-term outcomes. We're also going to get, we're getting information about patient, parent, and clinician preferences around treatment. We hypothesize that most patients would prefer the oral treatment if the efficacy is the same. But we are interviewing patients both initially and at 6 weeks so we can understand their experience with illness. This is a major collaboration because it's a relatively rare disease. And so we have 21 sites that are actively enrolling, all located in those areas where I showed that that Lyme disease was endemic in the United States. And we're really close to being finished. So we need 250 patients and we're at 246, which is really great. That's 98%. The hard part is we're sort of at the end of the season and we have 4 left. So we may have to linger into next year or we may get a few more. So I'm eagerly watching the enrollment. So I leave you with the doxycycline is most likely equivalent to ceftriaxone for the treatment of Lyme meningitis, but we don't have really high quality evidence for the short and long-term outcomes. And we hope to demonstrate that they are equivalent, but that data will be coming in the next few years. 4 more patients and the 6-month follow-up and time to write the paper. So if you give me a few years, but we'll write that up. All right, so our next case is a cross-country runner, a boy who runs his cross-country meet, finishes, has a personal record. And then a few minutes later, he's resting, his heart rate's coming down. He has a fainting episode, a syncopal episode, and he falls to the ground. The trainer who's at the meet runs over, but by the time people run over, he's responsive again. But it was a puzzling event. He fainted right after completing this exercise. So he gets brought to the emergency room. By that time, he's completely fine. He's hungry. He's, wants to go back to, being with his teammates. So I'm sorry for the colors, and I put this up early so you could look at this. I hope you see something a little irregular on this, which is the PR interval. Normally a PR interval from the P to the QRS complex is less than 200 milliseconds. This child has a 400 millisecond PR interval. Most children that you see don't have a prior EKG that you can compare to, but he's never had any syncopal episodes. He's healthy, but you have to always consider, could this be congenital? Could he have always had a long PR interval? But for acquired new first degree heart block or PR prolongation, if you're working in an area where Lyme disease is seen, you have to think about infection and causes. And actually, Lyme disease in our area is probably the most common cause of an acquired first degree heart block. And first degree heart block can, in settings sort of after exercise, as you come down, as the adrenaline comes down, can be related to fainting or syncopal episodes. It's usually a self-resolving episodes. Higher degrees of heart block can be related to actually more significant arrhythmias. Lyme can cause carditis and can have multiple manifestations. Heart block is the most common. This is from a series of 33 patients with Lyme carditis. And again, first degree with or without other changes was the most common finding seen. But a few patients had complete heart block, prolonged QTs, STT wave changes. So carditis, new evidence of EKG changes in the right clinical setting should just have you thinking about, is Lyme disease a clinical consideration or not? In an area where Lyme is endemic and we wait for a few days to get Lyme disease tests back, you can use the EKG as sort of a proxy diagnostic test or a diagnostic biomarker. So in a patient where Lyme is suspected, you can get an EKG. If you see first degree heart block, that is highly associated with having Lyme disease. So the odds of having Lyme disease if you have any type of AV block is 4.7. So it increases the odds of having Lyme disease. So it's sort of a quick Lyme test, a proxy measure while you wait for the definitive evidence. So for some, it's a routine practice when you're sending a Lyme test to get an EKG with or without cardiac symptoms, just to screen for carditis that may not be evident in any other way. How do you treat carditis or evidence of AV block? These children probably need to be hospitalized, particularly with a long PR interval like 400 milliseconds for telemetry. Typically, when they're hospitalized, they're going to get a parenteral antibiotic, ceftriaxone, and that PR interval can really narrow pretty quickly. So this particular child was hospitalized, and by 48 hours, his PR interval was back to normal. So even just by the hour, you can see it shortening on telemetry. And you're watching them closely for risk of arrhythmia, which this child didn't have, and most children with Lyme carditis don't. But still want to monitor in a setting where they could be treated if they did have a problem. And the Lyme tests come back positive, so first and second tier test. Once the PR interval is normalized, typically you don't need inpatient level of care anymore. They're really in the hospital more for the telemetry monitoring than the antibiotics per se, so they can be easily switched to an oral doxycycline to complete a 3-week course. Right. Last case for a rheumatologist, which I understand you don't see too often, but is one of the most common manifestations of acute Lyme disease that I see in my clinical setting, which is arthritis or right knee swelling. So you can see here, this child has a very swollen, boggy, but not that painful right knee. And classically, the knee is the most affected joint. It's very strikingly swollen, but for the degree of swelling, the child doesn't look that unwell. I mean, they may have some discomfort moving or walking, but they're able to bend it. And so that's sort of the classic clinical picture. We can consult our rheumatologist for additional features. But you're suspecting Lyme disease, but there are other things that cause a swollen knee, rheumatologic conditions, or the more serious condition of a septic joint, bacterial infection of the joint. And how much should you be concerned about that? So we've done some work looking at risk factors associated with Lyme disease and septic arthritis. And so you might start with your peripheral laboratory studies, a white count, an ANC, a SED rate, maybe some other inflammatory markers like CRP or procalcitonin at the same time that you obtain your Lyme disease testing, which is going to take some time to come back. And so the question is, do you need to do an arthrocentesis procedure? And the reason you do an arthrocentesis procedure would be to get a synovial fluid culture so that you can diagnose a septic arthritis. For a knee, it's not the most invasive procedure. You have a lot of local expertise in doing this procedure, but again, children don't like procedures. You have to think about whether they're going to need sedation. You have to make sure that people are trained and available to do the procedure. So, if septic arthritis is unlikely, then you probably want to avoid the procedure. The rheumatologists do joint taps for both diagnosis and therapeutic interventions. But in the emergency department setting where you have a patient with an acutely swollen knee, you're really thinking about diagnosis and excluding bacterial infection in the joint. We've done some work looking at predictors that are associated with septic arthritis, bacterial infection in the joint, and the factors that we identified in this cohort were the high ANC and the high SED rate. And again, this was work done before CRP was routinely available and definitely before procalcitonin was routinely available. And those biomarkers probably also have good diagnostic and discriminative ability. But those two factors alone did a fairly good job of excluding, a very good job, sensitivity of 100% of excluding septic arthritis of the knee. But septic arthritis of the knee is pretty uncommon, so the confidence intervals are pretty broad. So these are tools that you can use to risk stratify and think, is this a patient that I need to do arthrocentesis? One of the challenges of doing arthrocentesis, so this is some synovial fluid taken from the patient that I showed you in the first picture. And you see it's straw colored. What would you think if you saw this? Fluid colored, inflammatory, yes. And one of the issues is that all of these conditions that we're looking at are inflammatory and straw colored. So rarely do you get a big swollen knee with clear synovial fluid. And so when you look at the contents or you analyze the synovial fluid, it's not that helpful in figuring out what the cause of the arthritis is. And so that just can sometimes lead you down a diagnostic rabbit hole. So if you look in this graph here, the light blue dots are other inflammatory arthritis. The dark blue are Lyme arthritis, and then the red are septic arthritis. So you'll see that the white blood cell count and the synovial fluid for Lyme and septic are fairly similar. The ANC is fairly similar, and the percent poly. So sort of the traditional markers that you're looking at in the synovial fluid. So once you get the synovial fluid, the culture is important, the gram stain is important, but the actual white blood cell count doesn't help you really tell the difference. So you can have 100,000 white cells in your synovial fluid and it can be Lyme disease. So, but cognitively that makes you feel uncomfortable. And so I think sometimes you do the tap of the knee or the other joint, you get the high white count, and then you lead to other interventions that perhaps aren't needed when the end result is Lyme disease. But okay, what about this child? We did arthrocentesis because of the elevated inflammatory markers. They had a synovial fluid white count of 75,000. So that's, very consistent with Lyme disease. The gram stain and the culture were negative. So empiric doxycycline was started. The Lyme test came back positive. Classically, again, Lyme arthritis is a late acute manifestation of Lyme disease. It's, months after the tick bite. You can be bit by your tick in June and get your arthritis in March. And so at that point in time, you should probably have an IgG response. So most patients with Lyme arthritis are going to have a positive IgG. The treatment length for Lyme arthritis is the longest of the manifestations. So you want to do at least 4 weeks. And some patients don't have complete recovery at 4 weeks. And so sometimes they need a second line. And in even some cases, the Lyme disease can incite an underlying inflammatory arthritis. And so they may end up needing rheumatologic management and even disease modifying agents, even though the inciting in the first infections were Lyme disease. That's sort of a rare complication, but something that we see. Most children get better after 1 to 2 courses of Lyme arthritis. Okay, I'm near the end. But Lyme disease is common in the right geographic area. It may not be common here yet, but I wanted something to keep in the back of your mind because it can have a multiplex of manifestations and something for you to consider. But the challenge for clinician is, I showed you 6 cases of children with Lyme disease. Those same 6 cases could have a different end, right? They could have had other manifestations, different causes of arthritis, different causes of heart block. And so the overlap between Lyme disease and its mimics is why it's challenging clinically. We have imperfect diagnostic tests, and we have delays in those tests coming back, and we have to always suspect Lyme disease in order to diagnose it. The epidemiologic context is important. You're in a high Lyme disease area for Italy, but Italy is less Lyme disease than other areas. Remember to ask the patient about travel and other exposures. And so time of the year and travel and exposure are important in determining your pretest probability. The current diagnostics have limitations. They're the best we have in what we're using clinically, but there's a lot of work done in the laboratory looking at new approaches. So rather than a host-based response, can we actually directly detect the pathogen? That's a little challenging with Borrelia because by the time all the trouble and the disease happens, oftentimes the pathogen is gone. But in early disease, there may be ways to detect the pathogen, or maybe there's other host response things like an mRNA response or metabolomics or other things. And those are being investigated, and perhaps we'll have a different approach in 5 years, 10 years, but currently serology is the best approach. The direct detection methods like PCR, which are available now, are not very good for Lyme disease because, again, they're very insensitive. It's hard to find the Borrelia species available, but not all that helpful.